Hello and welcome back. So today I'm going to be discussing an approach to interstitial lung disease, starting with fibrotic ILD, interstitial lung disease, and we'll be discussing an approach to chronic dyspnea, and this under the general heading of approach to chronic dyspnea. This will be the 14th discussion under the rather large topic. So I plan to discuss this topic under the following headings. The first is obviously, as usual, there will be a logical approach to understand the patterns of fibrotic ILD. Okay, so the first thing I'll try to do is demonstrate that usual interstitial pneumonia is a lung injury pattern that is governed by the physical and biological constraints that are faced by pneumocytes, and these constraints are very analogous to normal aging of the lung. The second thing that I'll attempt to do is basically I'll try to make you understand how non-specific interstitial pneumonia, organizing pneumonia, and lymphocytic interstitial pneumonia are all three pathophysiologically similar and fall on a spectrum, and they are immunologically mediated. The third thing I'll be trying to do is understand the clinical implications of this spectrum and how that is used by those of us involved in diagnosing patients to decide on what type of pattern the patient might have, and therefore analyze images accordingly and then treat accordingly. Finally, or actually, I'll try to make you understand how lung injury patterns result from exposure to exogenous substances result in superficially similar but actually inherently very different reaction patterns. And then finally we'll try to derive a generalizable diagnostic framework for fibrotic interstitial lung disease. So this will be the general framework of the talk. So let's just jump right into it. So a usual interstitial pneumonia is, as I said, is a injury pattern that basically just represents accelerated lung aging. So the lung obviously is used for gas exchange and therefore is exposed to any and all types of inhaled toxins. Okay, so I've shown the two alveoli here. The alveoli are lined by two types of cells. These flattened cells are what we call the type 1 pneumocytes, and the columnar cells are what we call the type 2 pneumocytes. Now the type 2 pneumocytes do two very important functions. One I have shown in this diagram also, that is they secrete surfactant. The other is that when such an inhaled toxin causes damage to the type 1 pneumocyte, that is replaced by proliferation of type 2 pneumocytes, and these are the two biological functions that they perform. Now let's get into the details of this a little bit more. So again, these are the same two alveoli. What has happened is that because of that inhaled toxin, some of the pneumocytes that were lining the epithelium of the alveolus here have died, and the type 2 pneumocyte that I had shown earlier is now proliferating in order to occupy that space. Okay, now so the type 2 pneumocytes, I don't think this is very clear, but the type 2 pneumocyte proliferates to replace type 1 pneumocytes. Okay, that is what is written here. And because of this, simultaneously, any cell that is proliferating, any cell usually except for a stem cell, any proliferating cell has got a certain number of cell divisions that it can perform before it ends its telomere length reaches its terminal, the shortest length that is biologically safe. Okay, so what are telomeres? Telomeres are basically long repetitive sequences that are attached to the ends of the DNA at the ends of chromosomes. Okay, this is because when we replicate DNA, because of the miniature in which DNA is replicated at the replication fork. So these are two DNA strands that have been separated from each other during DNA replication. Now the thing is that replication moves obviously always 5 prime to 3 prime. So because of that, say this is 5 prime, this is 3 prime, and this is 3 prime, and this is 5 prime. Replication will move in this direction in this strand, and in this direction in the other strand. Now in this strand, every time you open up the replication fork a little bit more, you will have to again start replication. Okay, so what ends up happening is, by the time you reach the ends of the two DNA strands, there is a little bit of DNA that is always not replicated on the strand that is getting replicated in the opposite direction, that is in the 3' to 5' direction. So the final analysis of that is that whenever you replicate DNA, you lose a little bit of that of the DNA at the end of the two double stranded DNA. You're not able to replicate it. And if that was actual DNA that encoded for mRNA and then proteins, that would be technically be a type of mutation. Okay, and that would cause a lot of problems. So in order to protect the ends of the DNA, or to protect the cell from this kind of mitotic catastrophe, what is done is that the telomere length is lengthened. Now in stem cells, that length is perpetually lengthened, because the enzyme complex that elongates this complex of this polynucleotide chain at the end of the DNA is always active. But in cells that have differentiated, it is then shut down. Okay, now there is a group of clinical disorders called the telomeropathies. Now, with what is there in telomeropathies, there is a defect in the telomere, loss of function of the telomere, and we'll be discussing this as a separate topic later. But these are the genes that have been described as being part in some way part of the normal functioning of the telomere. Okay, for example, TERT and TERK are the RNAs that are part of the telomerase complex. Either way, so if you have a telomeropathy, what ends up happening is your type 2 pneumocytes have a shorter upper limit to the number of times they can proliferate, and therefore cover up the denuded epithelium of the alveolus. Now, see, to avoid this, naturally, people who produce type 2 pneumocytes that also simultaneously secrete matrix proteins that degrade the extracellular matrix and cause alveolar fusion would be selected for in the general population, and therefore that would be a common trait. Okay, so what ends up happening is that as these type 2 pneumocytes proliferate, they also produce enzymes. Okay, and what enzymes? They produce and secrete enzymes that degrade the extracellular matrix. Now, why do they want to degrade, or it's the term want can't be used because these are not sentient things, but why is it this important? How does this help? So I'll just explain this to you. So type 2 pneumocytes secrete enzymes that break down the ECM, because see, it's actually to do with math. So this is the radius of a sphere. The area of a sphere is given by 4 pi r square, obviously. Okay, and what ends up happening is that when you fuse alveoli together, okay, for a given volume, the effective area that is of that alveolus, of the two alveoli, actually decreases. So the type 2 pneumocyte now needs to divide fewer times to cover up this area. Okay, so it is in the overall benefit of the organism for the type 2 pneumocyte to not reach its replication absolute replication limits, and to fuse a few of the alveoli. So a little bit of alveolar fusion is not going to cause much of a problem. So that is what happens. Okay, so every time the type 2 pneumocyte is activated, not only does it proliferate to cover up the the empty space, the empty area that has been left by the dead type 1 pneumocyte, but it also secretes enzymes into the extracellular matrix that degrade the ECM and bring the two basement membranes of the alveoli closer together. Okay, so alveolar fusion also increases the effective internal radius of the alveoli, and this has an interesting effect on the surface tension that is there within the alveolus. So the surface tension is given by the Laplace function. That Laplace function is basically that tension is equal to pressure times radius divided by the width. So as the radius increases, what you end up having is you have an increase in the surface tension that is developed in the alveolus. So even though the effective area that has to be covered by the type 2 pneumocyte by dividing through division has decreased, the surface tension that needs to be countered now is higher. Okay, and this increase in surface tension is something that is very interesting, because which is the cell that has to produce this surfactant, and therefore to produce surfactant and therefore counter the surface tension? The type 2 pneumocyte. And that is what leads to our the conundrum that is faced by the type 2 pneumocyte per se. Now let's try to just visualize what is happening in the type 2 pneumocyte. So this is actually our endoplasmic reticulum. Okay, this is the cell membrane of the endoplasmic reticulum, and there are three proteins that are there in the cell membrane of the endoplasmic reticulum. Okay, this is a protein called IRE1, this is a protein called PRK or PERK, and this is a protein called ATF6. Okay, we'll talk about it now. Now, what has happened is this type 2 pneumocyte is now trying to produce a lot of surfactant. Okay, so it cannot keep up pace with the amount of increased demand on it for surfactant production, and also it has to divide, so it requires more protein production. Now as the number of the amount of protein synthesis increases, the number of misfolded proteins also increases. Now, when there's an increase in the number of misfolded proteins, that ends up causing a protein called BIP, okay, to separate from ATF6, to separate from PRK PERK, and also to separate from IRE1. Now, when this BIP is an inhibitor of IRE, PERK, and ATF6. So once BIP has separated from them, it results in the activation of these three proteins. And what does IRE do? IRE has got an endonuclease or endoribonuclease function. Now, specifically, it acts on the unsliced RNA, that would be the heteronuclear RNA of a protein called XBP1. So, in my recent discussion on the pathogenesis of inflammatory bowel disease, if you recall, I talked about XPOX binding protein 1. So this is the same protein. Okay. Now, with this endoribonuclease activity, it converts this XBP1 into spliced XBP1 RNA, eventually producing the actual protein, that is the XBP1 protein. Now, on the other hand, PERK results in phosphorylation of eukaryotic initiation factor 2 alpha, which is the rate limiting factor in basically initiation of eukaryotic translation or protein synthesis. Okay, so now that this is phosphorylated, it essentially shuts down further protein synthesis. So this would in a way allow the cell some time to prevent further misfolded protein accumulation. This also activates a transcription factor called ATF4. Okay, now the third protein, that is ATF6, that is transported from the endoplasmic reticulum to the Golgi via a protein complex known as the coaptomer complex, COP2 complex. Coaptomer 2 complex. Now, there's actually a monogenic alpha interferonopathy that results from the defect in this called COPA syndrome, and we'll discuss that at a later date. But in this particular context, what now happens is that the ATF6 protein gets translocated now into the Golgi apparatus, or the wall of this Golgi apparatus, and there it is cut. Its cytoplasmic domain is cut off, and it produces a free fragment known as ATF6 free fragment, or F. Okay, so the final effect of this is that we've got three essentially transcription factors that are being produced, and these then go and act on the target genes that are upregulated when you have an unfolded protein response. UPR stands for unfolded protein response. Okay, UPR. Okay, now see, initially when it is in small amounts, this is a self-limited process, misfolding stops, but the type 2 pneumocyte is not going to be allowed to essentially continue like this, right? So in that process, because it will keep happening to see the width by radius ratio will definitely keep increasing. Okay, and because of that you will end up having a lot of surface tension to counter, and because of that surface tension that has to be countered, basically the type 2 pneumocyte will have to produce a lot of surfactant, and it cannot get away with this level of misfolded protein accumulation. So eventually this entire process results in the death of the type 2 pneumocyte, and this leads us to the next step in the pathogenesis of uveal interstitial pneumonia. So now this is the type 2 pneumocyte in this alveolus trying to produce increased amounts of surfactant. Now because of that there is an increased ER stress response in these cells, and eventually these cells die because of that. Now polymorphisms in genes that determine how much this type 2 pneumocyte will get affected by this increased demand on it to produce surfactant protein are also responsible for, or they also increase the risk of development of usual interstitial pneumonia. So the most important one that we need to know about is the mucin 5b gene. Okay, this is this gene, and the others are transporters, that is in ATP binding cassette protein, ATP ABC A3 and ATP 11A, as well as the surfactant proteins themselves, that is surfactant protein A2 and surfactant protein C. So polymorphisms in these genes essentially result in increased or premature accelerated misfolding, and because of that accelerated misfolding we end up getting premature failure of these type 2 pneumocytes. Okay, now eventually because this type 2 pneumocyte is not able to cover up the entire epithelium, now there are portions of the epithelium that are essentially no longer intact. Now because they are not intact, you will have leakage of some proteins that are getting inhaled into the alveolus, into the extracellular matrix or around the alveolus, and that, as we know from our previous discussion on inflammatory bowel disease, results in the surrounding epithelium producing thymic stromal lymphopoietin, and that, as predictably would result in Th2 polarized immune responses. Now again, as would be expected, polymorphisms in genes that increase this kind of thymic stromal lymphopoietin production also predisposed or are associated in epidemiological studies with development of UIP pattern ILD. So those are these three genes, that is dipeptidyl peptidase 9, your desmoplakin DSP, which is a protein that is part of the adherase junction or the tight junction, and a protein called TOLIP. Okay, so these are the three clusters of genes that are associated with an increased risk of UIP, and I hope it is clear why. Okay, so telomere genes are responsible for premature telomere shortening. Okay, putting an upper limit to the number of times a type 2 pneumocyte has to can divide in order to compensate for loss of type 1 pneumocytes, and that would then result in increased secretion of extracellular matrix proteins. Now along with that would cause alveolar fusion, and when there is alveolar fusion, as we've discussed, the width by radius ratio actually increases. Because of that, the surface tension that is developed within the alveolus actually increases. So because of that, the combined fused alveoli require more surfactant than the normal alveoli. So this kind of surfactant production would preferentially affect those would cause premature type 2 pneumocyte unfolded protein response in those people who carry polymorphisms in these genes, because there's a second cluster of genes that is associated. And eventually when the type 2 pneumocytes also start to die, there is leakage of proteins from the alveolar lumen into the extracellular matrix around the alveolus, and that results in a production of thymic stromal lymphopoietin, and that eventually will result in an increased Th2 polarized response, and that will cause M2 macrophage polarization. So this is what happens. This is a step-by-step process, and as you can see, the amount of buffer that is there on either side for a type 2 pneumocyte is genetically dependent. Okay, now as a person gets older and this process keeps happening again and again, a 90-year-old human being or the centenarian, such a person will naturally start developing these lung changes, but some people develop them prematurely, much earlier than expected. Okay, so finally, what ends up happening is the extracellular matrix breakdown releases two matrix embedded growth factors, that is TGF beta and basic fibroblast growth factor, or FGF type 2. Okay, and these end up activating local fibroblasts that are embedded in the matrix around the alveolus. Okay, so this results in interstitial fibroblast proliferation and fibrosis. Okay, so now this process again is something that will result in myofibroblast formation, and we'll be discussing this in great detail when we delve into the pathogenesis of systemic sclerosis. But just to be, just to be complete, have a complete discussion of this. Basically, these fibroblasts, because of prolonged TGF beta signaling and FGF2 signaling, have two very interesting properties. They start to express the TGF beta receptor, and therefore they have autocrine TGF beta signaling. They themselves are producing TGF beta and responding to the TGF beta. Second thing is they are resistant to apoptosis, unlike other fibroblasts, and they convert into a special type of fibroblast called a myofibroblast, which is matrix embedded and expresses actin myosin in its cytoplasm and therefore can contract. Okay, when it contracts, it pulls the matrix inside into itself, and that is what creates that the pulling effect of fibrotic lesions. Okay, yeah. So this is your pattern of lung injury that occurs in interstitial pneumonia, usual interstitial pneumonia. Now this pattern of lung injury eventually leads to one, interstitial fibrosis, and second, alveolar effusion with very thin walled cysts. Okay, now why thin walled? Because again, that is to minimize the surface tension. Okay, so now the question remains is, would this kind of a process that is very barely or in a very few people mildly related to the immune system, but primarily affected by the physical constraints and the biological constraints that a type 2 pneumocyte is put under with lung aging, would this process show some differences in the general distribution, in the overall distribution of the lung? Okay, so that is, would there be a difference between the apical versus basal alveoli in terms of how they are affected, and or would there be any differences in how the involvement of axial, that is towards the center of the lung, and versus subpleural alveoli? Would they be affected differently? Okay, so obviously the answer is yes. Okay, and we'll try to deduce why that is the case. So this is obviously the lungs within the lung cavity. Okay, schematic showing that, and this is the diaphragm. This is the diaphragm, and this is the vector of the diaphragmatic muscle contraction and how the tendon moves. And we've discussed this in our discussion on pulmonary symptom analysis. Now this is the large vector of gravity. This is a person's chest, a person who's standing up. Now when this person is standing up, two things happen. Okay, one is the lung is obviously free floating within the pleural cavity, and therefore it is falling down. Okay, because of that, there is more negative pressure in this area of the pleural cavity as compared to this area of the pleural cavity. Okay, and so there's less negative pressure there, and this has an interesting effect on the alveoli that are there. Okay, that is, the alveoli at the top of the lung remain more distended at the initiation of inspiration. On the other hand, alveoli at the base of the lung are less distended prior to the initiation of inspiration. So what does this look like? So we'll just visualize this. So an alveolus at the lung apex, say it is this far, distended just prior to inspiration. At the peak of inspiration would be distend it only a little bit more. So say there's a 30 or 40% increase in the volume. Okay. Now, on the other hand, an alveolus at the base would be much less distended. As you can see, it's smaller than this alveolus. And however, at the end of inspiration, it would be essentially, as distended as those at the apex. Now, obviously, the change in volume from here to here is more than the change in volume from here to here. Okay, and therefore more work had to be done. Therefore, surface tension had to be countered more in this alveolus than in the alveolus at the apex. So the type 2 pneumocytes in the alveoli that are at the base of the lung have to counter more surface tension, and therefore are usually at more, have more of a requirement for production of surfactant than those at the apex. Okay, so basically alveoli at the lung apices need to overcome less surface tension to distend to full volume. Alveoli at the lung bases need to overcome more surface tension to distend to full volume. And type 2 pneumocytes at the lung apices therefore need to produce less surfactant. Type 2 pneumocytes at the lung bases therefore need to produce more surfactant. And because they need to produce more surfactant, they are particularly affected by a pathophysiology that puts type 2 pneumocytes at increased risk of unfolded protein response, i.e. are usually interstitial pneumonia. Now, similarly, in an analogous manner, type 2 pneumocytes in the center of the lung, that is towards this area of the lung, versus type 2 pneumocytes at the subpleural regions, okay, would have similar changes. So those at the center of the lung are actually not distending that much during inspiration, okay, because the pressures are coming from the negative pleural cavity. Okay, whereas these alveoli here are actually sandwiched between two layers of expanding chest wall. Okay, so they get expanded a lot. Now, because of that, again, they are the ones that are most significantly affected, because they are the ones more likely to develop an unfolded protein response, and they are the ones that are most likely to die. So what we end up getting is a lung fibrosis pattern, which resulting from this type of pathogenesis produces a very characteristic basal and subpleural initial fibrosis followed by cystic change. Okay, and this entity is what we term as usual interstitial pneumonia. So it stands to reason that usual interstitial pneumonia should be basal predominant. Okay, it should be subpleural, and it should initially, it can be fibrotic, but eventually there will be subpleural and basal predominant cystic change. Okay, and we'll see in our next discussion on the radiological aspects of this that this is actually what the Fleischner Society guidelines also prescribe, okay, as diagnostic criteria for the same. Now, see, the geographic pattern is the result of this complex interplay between the physical constraints of the lung and the type 2 pneumocyte response to injury, the biological response to injury. But this is not mediated by an immunological process, at least in most people. Some people have those that the leakage problem between the pneumocytes, and therefore they have more Th2 polarization as a driving factor in development of UIP-ILD. But in most people that is not the case. Okay, so in most UIP cases, it is not a predominantly immunologically mediated process. Now, what is immunologically mediated process is these three entities, that is lymphocytic interstitial pneumonia, non-specific interstitial pneumonia, and cryptogenic, or actually just organizing pneumonia. If there is no primary disorder associated with it, then it is called cryptogenic organizing pneumonia. So the thing is, it depends on what is the immune response that is activating it. So obviously any immune response is of two types. There's an innate immune response and there is an adaptive immune response. In this particular situation, in patients who have immunological disorders of this sort, there is neutrophil and macrophage mediated damage to the lining of the alveoli, and that induces secondary leakage of the epithelium, much like what we saw in case of the skin in atopic dermatitis, how in psoriasis secondarily there was a Th2 polarization, and we also saw that same thing happening in patients with Crohn's disease with secondary damage to the epithelium resulting in some degree of Th2 polarization. So a similar process happens here, and the interleukins produced by this kind of Th2 polarization eventually result in fibroblast activation, and the M2 polarized macrophages also produce the specific signaling molecules that result in further fibroblast activation. So see, this fibroblast activation is not the result of the the physical and the biological constraints put on type 2 pneumocytes. It's actually just dependent on where the immune related or immune mediated damage to the lung has occurred. Okay, and the M2 macrophages also produce matrix metalloproteinases, and they can result in matrix degradation, resulting in fusion of alveoli and cyst formation. Okay, but again, it depends on the genetics of the patient and the actual how much matrix metalloproteinase is produced, how much fibroblast proliferation occurs, etc. So if there is a very prominent production of matrix metalloproteinases, then you get a predominantly cystic process called lymphocytic interstitial pneumonia. On the other hand, if you have a lot of fibrosis, that is fibroblast activation, then you get what we term non-specific interstitial pneumonia, okay, which is a fibrotic ILD. On the other hand, if there is a lot of fibroblast proliferation within and there's an extension of those fibroblasts into the lumen of the alveoli, that can produce a consolidative process, as we've discussed in our discussion on consolidation in this series previously, and that is what we call organizing pneumonia. But as you can see, these are all resulting from innate immune activation, okay, and eventual adaptive immune activation. And although I've not shown it in this diagram, this innate immune activation is often in most systemic autoimmune disorders a type 1 interferon mediated process. Okay, now this type of immunologically mediated process therefore would not have a similar geographic distribution, is what we would expect. Okay, because there's no reason for it to be basal predominant or subpleural predominant. Okay, but actually there is a reason for it to be basal predominant, and we'll see that. Okay, so LIP, NSIP, and organizing pneumonia are three lung injury patterns that are immunologically mediated, and the only thing is that NSIP and even organizing pneumonia to some extent do show a basal predominance or can show a basal predominance, because these are immunologically mediated, and immunological cells come via blood flow, and blood flow to the base of the lung is 16 times that to the apex of the lung on average. Okay, so any process that is hematogenously entering into the lung is going to affect, but just by chance, affect the base of the lung a lot more. So that basal dominance can be seen in NSIP. Okay, but how we use it diagnostically is that if there is no basal dominance, UIP is very unlikely. Okay, so it's much more likely that NSIP would not affect the bases preferentially than UIP, because UIP by definition, by its very mechanism, has to affect the lung base and the subpleural regions first. Okay, now, so where does this leave us, those of us who are interested in diagnosing individual patients? Basically a spectrum of fibrotic lung diseases forms. Okay, on one end you got your usual interstitial pneumonia, which is a purely or almost purely a lung injury response to the physical and biological constraints that type 2 pneumocytes get put under when the lung is exposed to exogenous inhaled toxins. Then we've got NSIP, which is a fibrotic response of the lung in response to interferon production, type 1 interferon production, and innate immune activation subsequent to that type adaptive immune activation. And finally, we've got lymphocytic interstitial pneumonia and organizing pneumonia, which are the same as NSIP. The only thing is that LIP, there is more matrix metalloproteinase production and therefore matrix degradation and alveolar fusion. And in case of organizing pneumonia, the fibroblast proliferation is so florid that they start extending into the lumen of the airways after degrading the basement membrane of the alveolus, and as a result result in alveolar consolidation. Okay, but these are part of the same biological spectrum. Okay, now UIP, as we have just deduced, should show almost always a basal and subpleural fibrosis with or without cyst formation. Okay, NSIP can show basal predominance. Okay, but initially there will be inflammation, so it will be ground glass opacity, followed by fibrosis. Now there is subpleural involvement, there is no reason for it to be there. Okay, it can be there, but there is no absolute reason for it to be there. So if it is not there, it essentially rules out UIP. Okay, it could be NSIP, but it rules out UIP. Okay. Now, lymphocytic interstitial pneumonia show deep-seated or randomly distributed cysts, and organizing pneumonia similarly shows consolidation without subpleural sparing, because again there is no reason for subpleural sparing here, unlike in UIP. So something very interesting happens. Okay, this this seems like a very esoteric, very unnecessarily complicated understanding of something that can just be randomly remembered, much like a lot of things I discuss on this channel. But obviously there is a lot of nuance to this, and that helps you diagnose diseases. So that is why I've gone into so much detail. And these different lung disease injury patterns show very different etiologies, and therefore they respond very differently to immunotherapy, and that is why it is important to know them. So let's talk about the clinical implications of all of this. So we'll just compare these disorders. So usual interstitial pneumonia is, in up to 25% cases, there is a demonstrable or known genetic risk. Okay, and these were traditionally considered to be idiopathic ILD. But see, when a detailed history is taken, almost everybody has a history of smoking exposure and or occupational environmental exposure to some kind of inhaled toxin. Okay, non-specific interstitial pneumonia can be an isolated lung immunological disorder, or it can be part of systemic autoimmune disorders. And organizing pneumonia occurs in these entities. That is, it occurs on exposure to amiodarone and erlotinib. It occurs most commonly actually post-viral pneumonias, and less commonly with other pneumonias. It occurs as a part of the systemic autoimmune rheumatic diseases, and it occurs when you have graft versus host disease. Okay. Now, therefore, organizing pneumonia is associated with autoimmune diseases. Okay. Now, prevalence of usual interstitial pneumonia is actually 50 to 200 per lakh population. It shows a slight male dominance, and it naturally, because it's a type of aging related lung problem, it occurs in older people, usually more than 65 years of age. And since I've discussed, there are 3 clusters of genes that increase risk of usual interstitial pneumonia. It's to be reasoned that a family history is often there. Okay. Now, in non-specific interstitial pneumonia, there's a female dominance, even if it is idiopathic, quote unquote. That means isolated lung NSIP. Okay. Idiopathic happens in the 5th decade of life, that is between 50 to 60 years. Okay, for 40 to 50 years rather. Okay, and the systemic autoimmune rheumatic disease related occurs a little bit earlier, that is between 20 to 40 years of age, because that is the peak in the age at which most systemic autoimmune rheumatic disorders occur. Now, family history, again, especially in idiopathic cases, is positive. Organizing pneumonia occurs equally in male and female, and there is no specific age of presentation. Now, the clinical presentation from history actually doesn't allow for adequate differentiation of these 3 disorders. Okay, all 3 disorders present with a dry cough. Okay, usual interstitial pneumonia and non-specific interstitial pneumonia present with gradual onset progressive exertional shortness of breath or dyspnea. And when idiopathic, usual interstitial pneumonia is often associated with digital clubbing. So that is something that is a giveaway, and actually means that it is not likely to be related to a systemic autoimmune rheumatic disease. Whereas organizing pneumonia produces shortness of breath, but that is more subacute in presentation, so usually a few weeks. But again, chronic dyspnea is more than 4 weeks, so by that definition, most of these cases will also become chronic dyspnea. And the other thing with organizing pneumonia is that you have prominent constitutional features that like fever, fatigue, and malaise, because that is what is inducing the innate immune activation is what is inducing the fibrous proliferation. So because of that also produces the classical symptoms of a acute innate immune activation process. Now, response to glucocorticoids, UIP is not immunologically mediated predominantly, so it's poor. Okay, with NSIP, it is good, but it is good depending on the primary disease that is responsible for it. Okay. uh, with organizing pneumonia, in fact, the response is almost universal. Okay, it is every single patient usually responds rapidly and very significantly. Prognosis wise, obviously UIP has the worst prognosis with a 50% mortality rate in within 3 to 5 years of initial diagnosis. NSIP is much better, as in, it's 50 becomes 15 is how I like to remember it. So it's around 18% in 5 years. And there are two radiological subtypes, of actually histological subtypes. In that, cellular has got much better prognosis than fibrotic because it represents an earlier stage in the evolution of the disease. And organizing pneumonia actually has very good prognosis, and as long as the primary disease is managed, patients respond very well. Now let's just try to derive the lung injury patterns in different systemic autoimmune rheumatic diseases. So in rheumatoid arthritis, interestingly, the most common lung injury pattern is actually the usual interstitial pneumonia pattern. The reason is rather interesting, and we'll come to it. In dermatomyositis, literature says it is UIP equal to NSIP, but that is because a specific subset of dermatomyositis, that is antisynthetase syndrome, gets clubbed inside this category, and that is more diffuse alveolar hemorrhage rather than UIP. But yeah, this is what is written in Harrison. Finally, systemic sclerosis, SLE, and Sjogren's syndrome present predominantly with NSIP more than UIP. Why? Because innate immune activation with interferon production would be occurring there, and that's what is responsible for the prominent NSIP development in these disorders. On the other hand, diffuse alveolar damage or very severe lung damage is a pattern that develops in dermatomyositis, particularly MDA5 positive, and some very severe cases of antisynthetase syndrome, and in systemic sclerosis. Okay, that means it's very severe fibrosis. That is what it means. And lymphocytic interstitial pneumonia specifically occurs in SLE and Sjogren's syndrome, again because that is where type 1 interferon production is at its peak. It is diffuse in case of SLE, and it is usually focal in case of Sjogren's, because Sjogren's is an anti-epithelial immune response which shows some predilection for certain areas of the lung. Okay, basically the lower lobes because of lung blood flow. And okay, finally, we've got organizing pneumonia. So organizing pneumonia occurs with all of these disorders, and technically it can happen with Sjogren's also, but I wanted to highlight one specific type of Sjogren's related lung involvement, that is bronchiolitis obliterans, which otherwise only happens post lung transplant. So bronchiolitis obliterans can occur with a systemic disorder, that is Sjogren's syndrome. It also happens post lung transplant and with graft versus host disease. Now, predictably, the risk of UIP pattern in RA patients is increased in smokers, and around 10% of patients with RA develop a clinically evident lung involvement, but radiological evidence is often present in almost half of all RA patients. It's not routinely recommended to do imaging in these patients because, unlike in systemic sclerosis, the lung fibrosis is unlikely to rapidly progress. Okay, it progresses in less than 4% of all RA-ILD patients. It's usually quite stable, and some people even show improvement. Now, this is due to your co-inheritance of the mucin 5B gene mutations, and possibly other genes that we discussed in those three clusters at the beginning of the discussion. And dermatomyositis to Sjogren's syndrome, these are all type 1 interferonopathy, so there's a lot of interferon production. Bronchiolitis obliterans occurs in Sjogren's because of anti-epithelial immune responses. Okay, now the mucin 5B polymorphism RS357-05950 is seen in around 35 to 45% of all idiopathic pulmonary fibrosis cases, but is also present in the general population. So other genes in those three clusters also have an effect on the risk of developing of idiopathic of IPF or idiopathic pulmonary fibrosis with the usual interstitial pneumonia pattern. Now, there are lung disease, autoimmune diseases of the gastrointestinal tract, because the gastrointestinal tract has blood flow that is going into the right side of the heart and then into the lung. also often have uh, have a increased risk of developing lung injury patterns. And there are three of these disorders: IBD, interstitial bowel disease, primary biliary cholangitis, and autoimmune hepatitis. I hope the sequence of uploading of the discussions has shows is quite clear from this. uh, Finally, non-autoimmune systemic disorders also can develop some similar fibrotic ILD. And these disorders are they are not, you see, just because they are not autoimmune disorders, that does not mean that they are not immune mediated. Okay, because all tissue injury which is not exogenous is immune mediated. So the disorders that can come under this in this category are your genetic disorders. So genetic disorders, I remember using the mnemonic glyceryl trinitrate, so GTN, that is Gaucher's disease, T for tuberculosis, N for neurofibromatosis, and N for Niemann-Pick disease. And along with that, Hermansky-Pudlak, we have also not discussed this while discussing IBD. I am not going to discuss it right now as well. As would be obvious, in both situations, there it is a immunologically mediated process. Now, tuberous sclerosis, importantly, is more commonly associated with a non-fibrotic ILD pattern called lymphangioliomyomatosis, and lymphangioliomyomatosis we'll be discussing in our discussion on. So we'll be discussing it along the course of our radiological discussion in detail. Now, most ILDs resulting from occupational inhaled toxin exposures are fibrotic ILDs. And see, they have very similar pathogenesis to whatever we saw with usual interstitial pneumonia. However, usual interstitial pneumonia is against inhaled non-particulate particulate toxins. And these occupational lung disorders are usually due to inhaled particulate matter. And particulate matter usually that is less than 20 micrometers in diameter. We've discussed this in our discussions on ILD, on the assessment of ILD patterns earlier. And because the upper lobes, or the alveoli within the upper lobes, are less well ventilated, as in they change, their total volume is replaced over a more number of respiratory cycles as compared to the lower lobes, the alveoli in the lower lobes. Therefore, such particulate matter tends to deposit more in the upper lobes. Okay, so we end up with two types of occupational lung disorders. Ones that show upper lobe dominance. Okay, and this is basically what I was just trying to say, that alveoli in the lung apices have a longer particle washout. That is, they take more number of respiratory cycles to completely change the air within the alveoli. Refer to our discussion on interstitial lung disease imaging in the same series. So particles less than 30 micrometers in diameter therefore end up getting deposited there, and then they are not expired out, and that is where the immunological response to this occurs. Asbestosis is abnormal in this regard, because asbestosis, the particles have a very specific shape, okay, very streamlined aerodynamic shape, and that causes them to follow the laminar airflow, and as a result go towards the lung bases and towards the periphery of the lung. Okay, so other than for asbestosis, every other occupational lung disorder ends up affecting the upper lobes of the lung. Berylliosis specifically induces a granulomatous response, and that can make it look very similar to sarcoidosis, and we'll be discussing that at a later date. Now, finally, our discussion has led us to understanding, I hope I have demonstrated, that usual interstitial pneumonia is a lung injury pattern governed by the physical and biological constraints that are faced by type 2 pneumocytes, which is very analogous to what happens with normal lung aging. Second, I hope you understand how non-specific interstitial pneumonia, organizing pneumonia, and lymphocytic interstitial pneumonia patterns form a pathophysiological spectrum. Third, I hope you also understand that what are the clinical implications of this spectrum and what workup needs to be done, what primary systemic autoimmune disorders need to be evaluated for, or genetic disorders need to be considered in these specific with these specific lung patterns. I hope I have also made it quite clear how lung injury patterns resulting from exposure to exogenous substances result in superficially similar but actually very different reaction patterns. Now, finally, I said I would derive a generalizable diagnostic framework for fibrotic ILD. That is a consolidated diagnostic framework for fibrotic ILD. Now, the issue with this requires understand analysis of the imaging of interstitial lung disease, and I will be discussing that in the next video in this series. So we'll derive the diagnostic framework at that point of time. Suffice to say, however, that the primary driving no, logical principle behind the diagnostic framework will be that UIP pattern is very dogmatic. That is, it will show a basal predominance. It will not spare the subpleural areas, and that is what we will be using in our diagnostic framework. So that'll be interesting, and I hope to see you in the next video. Thanks for watching.